All right, welcome everyone to our COVID-19 DPC Town Hall. We're mobilizing DPC to fight this terrible virus that's gripping the country and the world. And with us, we have Executive Director of the DPC Coalition out of Washington, D.C., Keese. I'm Nick Wells, the head of marketing for Hint Health. And I'm here bunkered down in my San Francisco apartment, as I will be for the next unknown number of weeks. So Jay, welcome. Thank you for your, you've been with the DPC Coalition since the beginning, since 2009. And I understand you've been in Washington for just about 30 years. But I hear that I know that you're celebrating a different milestone yesterday. So congratulations on 25 years of marriage. Maybe congratulations to your wife for hanging in there for 25 years.
Sure. We're still trying to figure out why she said yes, but all that is,
some mysteries were never meant to be solved. So Jay, thanks for coming on. I know that a lot of our audience knows you and has seen you speak at Hint Summit and at other conferences, and knows you from the steering committee and the fly-ins that you host in DC. So we've got, I've got a lot of questions for you here, and I know that the audience will have a lot of questions for you as well. So let's see where we are. We've got, everyone's sort of trickling in now. So I just want to let the audience know, at the bottom of your screen, there's a Q&A button. So you can click the Q&A button and you can ask your questions there. So don't put them in the chat bubble, put them in the Q&A button. And then once we get through sort of these initial round of my questions, we're going to go to audience questions. And we'll go lightning round through those. Just pepper Jay with them. All right, Jay. So first question I have for you is, can you talk about tell us more about the CARES Act? I know that you were very involved behind the scenes of HR 748, the $2 trillion virus relief package that just finally passed. I believe it was late last night. Can you tell us a little bit about what happened, what was going on behind the scenes, and what's in that package that the DPC community needs to know about?
Sure, Nick. And yeah, I mean, it's been one of the interesting things about beyond the crisis at hand has been that everybody, including most of the staff and members of Congress, as of a couple of weeks ago, everybody's teleworking. So one of the things that happens all of a sudden is you're working 24/7, and that's really the pace that this has gone at. We've passed. This is our third major stimulus package that we've passed in less than a month. And of course, this one, as you've probably all heard on the news, is the largest stimulus package of its kind. So whopping, $2 trillion. And there's a number of things on it. I'm not going to focus, on any of the tax relief and on any of the, employment incentives. But, I think it's fair to say that there's probably more health policy being done here than in any piece of legislation since the Affordable Care Act. And my guess is that by the time we get through this process, there will probably be more that will come out of here, come out of this effort, and the regulatory side and the other bills and the bills we're about to have than there was in the Affordable Care Act. And I think it boils down to really one thing. Both Congress and the administration are trying to do absolutely everything they can to remove, at least in a temporary sense, and upon evaluation in a more permanent sense, to remove as many barriers as they possibly can to doing virtual care. So this has been a great opportunity for DPC because, obviously DPC practices do virtual care every day. It's the way you all, who are on the webinar here, do primary care. I mean, my relationship with my doctor is such that, I've been to see him a couple of times. I actually, because he works with us at the coalition, I probably see him more for lobbying than I do for doctoring. But when I need to contact my doc, I open up my Spruce app and I talk to Matt and we have a conversation. Just like I open up my iPhone and get my messaging, iMessage and chat with you when I want to get a hold of you. It's like, so the rationale obviously for the DPC practices has not been, hey, I'm doing this because I can get paid in this new telemedicine code. It's the way we communicate with our patients. And I think there was a big aha moment around town, when this thing hit. We're gonna have to move to this overnight, and really in a 2-week time frame. We went from having telemedicine as this rare thing that maybe a couple of these DPC docs over here did, and there were some telemedicine companies like Teladoc and Amwell and others, but it was sort of an anomaly, to telemedicine becoming medicine. And of course now, with all elective surgeries and all elective procedures, and really all but the most urgent needs and treatment of COVID being done virtually, the entire effort that's going behind this has really been to try to facilitate virtual care. And as such, the DPC provision was, the Primary Care Enhancement Act was put in among a group of other telemedicine reforms as a way to try to enhance that, and to take the last remaining barrier to DPC in federal law that's a major hurdle to expanding DPC, is this incompatibility with the HSA. So the provision that Senator Cassidy and Representative Blumenauer have put forth in their bill, it's actually the Senate version of the bill, was added to the first version of the bill. And then of course, you probably all heard that this legislation immediately became a political football. Democrats were accusing this of being a huge corporate welfare bailout. Republicans accusing Democrats of wanting to move to socialism and start the new Green Deal, and all the other things on the Democratic ideas. And long story short, there was really an objection to the Primary Care Enhancement Act on the part of one individual, and that happened to be one of the individuals that was at the table negotiating. That objection was made based on the antiquated notion that DPC is just concierge care, and so this would just be another program for the rich that would be a Republican platform. So we know that's not true, and in fact, the provisions in the Primary Care Enhancement Act don't actually apply to concierge practices who practice in a fee-for-non-covered service model. And if we ever needed any insight in the middle of all this lobbying storm, the largest concierge medicine practice company in the country, MDVIP, actually weighed in and asked that there would be report language associated with the provision in the bill that would clarify that it doesn't apply to them. So, we got stripped in the heat of battle because of a misunderstanding around this being concierge. Of course, there's also in the legislation, everybody's probably aware, there are limitations put on for HSA holders only about what these provisions, what these practices can charge. They're $150 per month limitation to apply for the exceptions that are in the bill, to have them apply to a DPC practice. That is also another tool that's in this bill that was specifically designed to address the concerns, number one, of the cost of the package, and number two, the question, would this be concierge for the rich?
Hey Jay, quick follow-up question there.
Yeah.
With that $150 limit, I know that's been a sticking point with some people in the community. That doesn't necessarily mean that a DPC practice couldn't charge more if they wanted to than $150 per month for their services. Doesn't that just mean that somebody with an HSA could not then choose that package?
Correct. So what the provision says, the provision is tied very, very narrowly to the Internal Revenue Code, to the provisions in the Internal Revenue Code that set up the conditions for eligibility for an HSA. So the primary problem that DPC has is that if you have a DPC arrangement, it's looked upon as a second health insurance plan by the IRS, by nobody else. Not by the Department of Health and Human Services under the Affordable Care Act, essential health benefit rules, not by 30 state legislatures that have passed laws or regulations, 30 plus now, defining DPC. It would have absolutely no bearing on that. But for this last little nitty gritty part of the tax code, which defines any arrangement which aggregates services that cover services that are already covered by the high deductible health plan is considered a second health plan. And that would make an individual ineligible to fund the HSA. So by putting the $150 cap there, it's saying, hey, this is triple tax preferred income. We don't want triple tax preferred income going to high dollar, basically concierge or DPC concierge practices. We don't want that level of tax deductibility. We don't want that tax benefit. It's a $1.8 billion hit on the Treasury to do that over 10 years. So that was a way to limit that number and assure that these plans, were not being offered, to the wealthy as a Benny. It does not mean you couldn't charge more for any other patient that doesn't have an HSA. And I think the reality is, once the provision once the rules are made around the provision, it doesn't prevent you from charging for, certain other services that are outside of primary care, like prescription drugs, for instance. That was one of the provisions we actually got stripped from the original House version of this when it passed last year. So we were happy to see that, and that pharmacy provision was pulled when it made it into the original part of the CARES Act. I also want to make a clarification about the CARES Act. I hope people understand it has passed the Senate. It's pending a vote in the House of Representatives tomorrow, and there's been a lot of drama over this. You may have seen reports that I think from the left and from the right, AOC and others are objecting to the amount of pork that's in the bill, or it doesn't have enough pork, it doesn't have the new Green Deal, so we're gonna object. The Speaker has the authority to bring, the couple of members that are there to the floor, ask unanimous consent. If nobody will object, they can pass this by voice vote. There will be an objection tomorrow. So what's happening right now is that 218 members who we know support the bill are flying back into Washington to make sure that magic number 218 is the number you need to pass a bill by a simple majority. So they're going to have 218 yes votes on the floor tomorrow, just in case, no matter what. And frankly, it's a public health concern to have to do that. And people are coming back, traveling in the airline system, coming back from their homes, risking exposure, risking potential exposure if they're healthy and they're a carrier to somebody who's not healthy. And but that's the way it's going to go down. And I have. I've said a long time ago, my crystal ball is cracked. I'm not really sure I'm in the prediction making business right now, but I think every individual that I know of is hoping and praying that this package does get passed, and if for no other reason than the markets don't crash again on Friday afternoon if it looks like a deal is not apparent, but there's been a lot of drama about that, and it's a shame we got pulled, but there's a lot of other provisions that I'll get into tonight that there's a lot that wasn't done in this bill. We are going to come back and do another bill. There's no doubt about that. The target date for members coming back after this vote is April 20th, and there's really two key things that have been on the top of the agenda that are not in this bill. And one is a surprise billing package that's been pending before Senator Alexander's committee and pending in the Congress for over a year. And then obviously the prescription drug legislation has been top of mind for a lot of folks. But one of the things this bill did is it took all of those Medicare programs, all of those programs that needed to be refunded, and kicked them to November 30th. So the bills that were supposed to be reauthorized by May 22nd, which is when we were hoping to have our vote on the Primary Care Enhancement Act, we have until November 30th to pass those. So we've got a couple of other bites at the apple to pass this. And the fact that we made it into the original package is really amazing. It's astounding, particularly given the fact that, it's no secret there's been some opposition from some of the smaller independent doctors that are very free market oriented, that don't like the restrictions that have been put into the bill. And so, we've been lobbied against by the liberals and we've been lobbied against by the conservatives. And we are caught in the middle where all the rational people are trying to get some good policy done.
You got to start somewhere when it comes to policy.
Yes, you do.
Something
Yes,
better
you
than
do.
nothing.
But unfortunately, we started this process 10 years ago, and we'd like to get it wrapped up this year. And I really do. I've never felt more bullish about being able to get this particular piece done. And then we've got other things we need to move on to. I mean,
Yeah.
the other thing that this is proving, needs to get fixed. We've got to fix the Medicare opt-out piece, and we're working on that. We actually have a request for guidance in from CMS, and I think there are some provisions. I think Phil probably talked about these last week, but already in existing law, if you do emergency care or urgent care, you're accepted from those opt-out restrictions. So if somebody comes to you, let's say you wind up having to be pressed into service, or you're volunteering your service either in a telemedicine capacity or going to a hospital to take care of somebody, and you're an opted out physician, if you're treating somebody on an emergency basis, and any COVID patient would either be emergency or urgent care, there's already an exemption for that, and so you could do the fee-for-service billing. We know that's not DPC. We'll talk about some of the telemedicine restrictions that have been lifted. I mean, literally every restriction that we can imagine on telemedicine, except for one, has been waived, lifted, or enforcement has been stopped. And we can go through, one by one, sort of what some of those are. And I'm happy to go through some of the other points in the bill too, because I think those are key as well.
Sure. Yeah. Before we move on to the other topics, can you tell us who it was that objected to the Primary Care Enhancement Act part of the bill? So
Sure.
At least you know who to reach out to, and really in terms of supporting the measure,
Yeah,
letting the person know what DPC is really all about.
And we will certainly share some talking points that we put together that are actually entitled "DPC is not concierge care," and we can run through some of those, and I'll have those available for you to share with folks on the website when we post this up. It was and I want to say what we don't want to do is we don't want to go pummel this office with rocks and garbage. This was done in the heat of the moment. This was probably, to be candid with you, a 10 to 15, maybe 20-second exchange. It happened more at a staff level, at the member level, but it was the ranking member of the Senate Finance Committee, Ron Wyden, and his staff that objected to the provision. They objected to a whole lot of other provisions as well, and this was part of a delicate dance between the reforms that the Republicans wanted and the reforms that the Democrats wanted, and this one just sort of stuck out there like a sore thumb. One of the things that I think that was missing to them was, what's the relationship to COVID if we are going to extend benefits to these private medicine services? And clearly there was not a robust discussion about how DPC practices just do telemedicine as a part of the regular way of doing business.
Gotcha.
So let's not immediately attack Ron Wyden, because he's still going to be ranking member of the Senate Finance Committee. Any of these other bills we need to get through him, we're going to have to explain to Senator Wyden why this is not concierge and why this is related to COVID, because everybody's doing virtual medicine now. The fact is, with these restrictions under current law, without any other kind of waiver that's been put in place, and there isn't a waiver to my knowledge that's this broad, 23 million Americans who have high deductible plans linked with HSAs are not technically, legally eligible to have a DPC arrangement. Now, we all know that has been wildly not complied with, but still, it's a ridiculous piece. It's got to change, and we are literally first and goal for having that change made in a legislative sense, and I think we're going to be able to do it.
Great. Yeah, I mean, it's all about an educational campaign.
Absolutely.
We just got to educate Washington. So I want to talk about virtual care more. One thing that, and we'll talk about what HINT's doing in terms of our push to sort of mobilize DPCs to provide virtual care to areas where primary care is, where services may be overwhelmed, either now or in the future. But with virtual care, there are state restrictions on providing virtual care across state lines. That is not a federal government thing. It's a state level thing. What's going on there? Can you talk to us about the things that you've heard or restrictions that have been eased on virtual care? You said all but except for one have been eased up federally.
Yeah, and that's the one I think you're referring to. I mean, the president got on TV, I think a week ago Friday, and said, we have this new authority under the Stafford Act, and we're going to be able to waive state medical licensure and allow health practitioners to practice to practice across state lines. And actually, that idea of healthcare across state lines has been a Republican political platform for some years. It doesn't candidly really mean a lot. In this case, it means a lot. Unfortunately, the president does not have the authority under the Stafford Act. It's a constitutional. It's a question of enumerated powers, and the powers for state licensure are ceded to the states. Tuesday, Secretary Alex Azar sent a letter to 50 state governors saying, look, we have put in place an Section 1135 of the ACA allows for a Medicaid waiver, which would allow the administration to do a lot of things in terms of waiving federal barriers to entrance and stuff. But the states are going to have to make the decision on a state by state basis as to whether or not they're going to accept doctors with licenses in other states. The Federation of American State Boards of Medicine has a list, and we'll send a link around. And I'm going to share this now. But so here's is that up on the screen?
It is, yeah.
Great.
And just to the audience, we'll be sharing any links and documents that Jay shares with us that we can share on our COVID War Room page at hint.com/COVID-19.
So this is presumably being updated every day. So this is today's version, and as we scroll through it, you'll see the states, and it tells you exactly what the changes are. I think about a third of the states, as of this writing, have made some either waiving enforcement, allowing people to get a temporary license, allowing any other practitioner, as I believe West Virginia has done, to practice. But this is the resource to go to. I think this is a pretty good and comprehensive list of all the states and what they've done. And really, so we're looking at Nebraska, Nevada. There's really only a couple of states left as of today that have not made any changes due to licensing or renewals because of COVID. And this is even out of date because, look, here's West Virginia. And I did see, I actually saw a tweet from the West Virginia Attorney General yesterday saying that anybody with a license in any other state is welcome to practice in the state of West Virginia. So the bills, the first COVID package, the Coronavirus Preparedness and Response Supplemental Act, did attempt to waive some telemedicine restrictions in Medicare. They made a drafting error because, again, done in the heat of the night, right? So the second, HR 6201, which was passed week before last, the House Families First Coronavirus Response Act, did correct the Medicare telemedicine provisions. So what the bill says, and this is statutory law now, CMS has the authority to waive any of the restrictions around Medicare, Medicaid, having to do with telehealth. So any original visit, any site requirement, any geographic requirement, any tie to a physical visit has been waived for the duration of the public health emergency. CMS has a set of FAQs on this, and let me see if I can share that as well. Did that get up?
Yep.
I
Can zoom out maybe a little bit or scroll over.
Hold on, I'm gonna get it again.
Sure.
here it is.
So just I'm going to use this moment to anyone who joined after the beginning of the call. If you have a question, we're going to get to audience Q&A in a bit. And there's a little Q&A button or toggle at the bottom of your screen. Might be on the right of your screen, depending on which software you're using. And you can just go in there and write your question, and we will get to as many questions as we can.
So again, long story short, there's a set of FAQs up on Medicare, but you know, the between the 1135 waivers and the Medicare telehealth waivers that have been done administratively, virtually all of those barriers to entry have been put aside. Now there is the question of the opt-out, and again, the answer there in the short run is if you're treating a COVID patient, or you're treating an urgent care patient, or you're treating an emergency patient that's coming through a telemedicine service that's coming from the outside, or through Medicare, or you're at another hospital, you know, you should be covered for that. But really, you know, sort of like effective March 6th, for the duration of the public health emergency, telemedicine visits are considered the same as in-person visits, paid at the same rate. And all of those restrictions around telehealth services that CMS has had in place for forever and ever have been removed. The bill itself that passed today has another interesting provision in it in Section 3701. Section 3701 waives so the telehealth services that charge a PMPM for telehealth services that are out there like Teladoc and others. Candidly, they have the same IRS problem that we have. So in a temporary sense, until the end of 2021, companies are allowed to offer a telehealth benefit to an HSA high deductible health plan eligible individual. They are allowed to pay for that benefit, and that benefit would not make an individual ineligible to fund their HSA. So there's a little bit of a shoehorn. Now, this doesn't mean that an individual can take money out of the HSA and pay the doctor directly. What it means is if you have a contract with a company that has a high deductible health plan, HSA eligible high deductible plan, that company could pay a $50 PMPM or whatever the number is, could pay the doctor that rate, allow for a telemedicine service that is part of a direct primary care arrangement that would be included, and you wouldn't be subject to those HSA restrictions, as long as it's considered generally to be a telehealth benefit. And as we all know, for the foreseeable future, all care is going to be telehealth. So you know, it's a good opening. We're going to work with CMS to see what we can do to try to expand that. It doesn't mean we're going to stop pushing for the bill, because we want a permanent solution. We also want a permanent solution for the telehealth piece as well. So the next round of bills that'll probably happen starting around the middle of April is going to try to take some of these things that were done temporarily and make them permanent, so that we can take all of these emergency restrictions that have been waived for telehealth and make them permanent. And that's another great vehicle for the Primary Care Enhancement Act to ride on. But I think in the short run, between that and, of course, there is the existing executive order on transparency. We've weighed in with the administration and Treasury, asking that they expedite consideration of that to clarify that direct primary care arrangements are, in fact, qualified health expenses under 213D. We're not sure whether they have the authority to fix the 223C problem that makes us ineligible, but I think with a wave of a hand, they could, if they wanted to, they could waive that. So we're working on the administrative front to try to get that done. We're working on the legislative front to make it permanent. And we've made some really good progress on that, and you know, we're hopeful that that'll come in the next round. But there is a little bit of light at the end of the tunnel in this 3701 removal of telehealth restrictions as well. So we're excited about that. We're going to look at it. It certainly isn't 100% solution or even a 50% solution. For one thing, it really doesn't take care of the small individual doc that's out there that doesn't have employer arrangements. So we understand it's not the world on a silver platter, but it's a good start, and we're super happy it's there. There's also in the legislation there is a full authorization of of the HRSA telehealth funds, which are out there, which would also sort of require the administration to do things like create more broadband opportunities so the telehealth works better. I don't know how many of you have experienced problems with Zoom and problems with bandwidth in the last couple of days, but it's clear that bandwidth is another thing that needs to be dealt with. So we're gonna be seeing a lot of stuff around telehealth, come out of this, and I think we'll be able to move to get a lot of it sort of more permanent.
Well, policy infamously lags technology, and I think we're feeling that right now, for sure.
No doubt.
But this, the silver lining, like you said, of this whole thing is that this is a chance, an impetus for the policy to catch up.
Yeah, I mean, I just see change. I don't think we'll ever go back. The genie is out of the bottle.
Moving on, the administration has been talking about everyone can have a free COVID test. Once our ability to test catches up. Can you talk about how that's going to work for DPC docs who work outside of the fee-for-service environment?
So the bill that passed the Senate today says essentially that if you have Medicare Advantage, private insurance, Indian Health Service, VA, DOD, any government health plan, any private health plan, that the private health plan has to pay for COVID testing and diagnosis and treatment with no copays and no deductibles. So it's no cost sharing. And there's also a provision in the first stimulus, or excuse me, the second stimulus, HR 6201, that allows for uninsured individuals to get a free COVID test. To facilitate that, Bob Kadlik, who is the Assistant Secretary for Preparedness and Response in HR 6201, got $1 billion fund to administer COVID testing for the uninsured, and anybody who's uninsured will have the government pay for a COVID test. We do not know how that payment structure is going to work at this point, but that fund was authorized by the legislation that was put forth. Plans obviously are being made right now to do these sort of drive-through tests and to have remote testing sites away from hospitals. And the long and the short of it is, we believe that there will be an ability for you to do a test, charge a patient, and have the patient get reimbursed for that charge if the patient happens to be uninsured. But none of those things have been worked out quite yet. One thing that is not in this bill is any restrictions on how much people can charge for stuff. So, so the surprise billing legislation is going to be really important. So in this new legislation, the hospitals essentially got a $100 billion bailout. And hospitals have been given carte blanche to really treat anybody in the acute care setting, fix corona, or anybody that needs any other acute care during the time of the crisis. They're going to get a boost. The payment cut they were supposed to get goes away, and they get basically $100 billion check to try to keep hospitals afloat during this time. That's also understanding that there will probably be a shortage of healthcare workers, and either recruiting new healthcare workers, bringing people in from the outside workforce, or just really propping up the system. But what's not in there is the surprise billing legislation. So essentially, anything the hospital wants to charge now has to be paid for by the plan. So I think it's going to be imperative to get this surprise billing legislation passed. And again, another potential vehicle for the Primary Care Enhancement Act to ride on. Senator Alexander, who's the sponsor of the Senate version of the surprise billing bill, we've been working with really closely, is a huge supporter of this legislation. We've already had conversations about using the money that would come from the savings of that surprise billing bill to pay for some of the offsets to the $1.8 billion that the Primary Care Enhancement Act would cost the Treasury over 10 years. So we're working that angle as well.
Great. So, and just a follow-up question there. Now, that was COVID-19 testing. What about screenings, or somebody goes in for something that they're concerned about COVID-19, ends up not being COVID-19? or they
Yeah,
end up.
screened. If you're being screened for a test, screening, diagnosis, treatment, testing. My understanding is it's covered.
Great. So sort of my last question is, we've talked about, you've touched a bit on this quite a bit. Other things that you're hearing in terms of executive action or other legislation that you think is really important that's coming next? You talked about the price transparency, or rather, the no surprise billing legislation that you believe will be coming through next. Other things that you think are coming next?
Yeah, let me touch on one other thing that's really critical in regulatory action that's happened, and it coincides with another piece that's in the bill. There was a general waiver on HIPAA that was issued by the HHS Office of Civil Rights. It basically says, during this time of crisis, we're not going to do any HIPAA enforcement of things related to telemedicine. So if you as a doctor pick up your very non-HIPAA compliant telephone and talk to your patient using the phone during this time, you're not under any risk at all for being enforced under HIPAA. Surprisingly, and in a very good piece of news, one of the provisions in the bill that passed the Senate was a harmonization of HIPAA guidelines for sharing data for people with substance abuse disorders. So people that have a diagnosed substance abuse disorder are not covered by HIPAA. They're covered by Part 2, CFR 42 Part 2, which are very old rules from the 1970s that basically say, if a patient has a substance abuse disorder and doesn't want their data shared with anybody, it doesn't have to be shared. So imagine what a problem that's going to be, sharing test data for somebody that has a history of substance abuse with COVID or with the opioid crisis. This was a piece of legislation that was stripped from the opioid bill. That was put in there. But what hasn't been dealt with is, you look at all the apps that are on here, and we know that a lot of the apps that we use with Spruce and Hint, they're HIPAA compliant. By and large, patient-facing apps that are made by third-party developers are not covered by HIPAA. They may be covered under California state laws and the EU provision, but there's really no federal law covering that. So I think we're going to get very quickly into the conversation about, okay, we've expanded to telemedicine and virtual health and digital health. There's all of these apps that are out there being used now to help treat and diagnose people, and they're all apps that patients can download on their phones as a means to communicate with their doctors. How am I protected? How's my data protected if I'm using that app? The short answer is it's not covered by HIPAA if it's a patient-facing app. If it's an app that's used between a doctor and a hospital, or a doctor and an insurance company, business associates, then it's covered. But we're going to have a massive expansion of our privacy laws to cover some of the stuff that's been done in the short run to make sure we allow virtual medicine to be practiced anywhere. And we're going to have to do something in the long term about how incompatible HIPAA is with doctors and patients using technology to communicate with each other. And I think that's a big one.
Well,
I also think there's going to be another massive bailout. So, I mean, this isn't the last time we're going to see hospitals, healthcare providers, other sectors. I mean, you think about all of the hotel service employees, restaurant workers, bartenders. Please go out and support your local bartender. I've seen these bartender funds that are out there. I mean, these people are really, really suffering. And, while Boeing and hospitals are getting bailed out, appropriately, we love the idea that Boeing's going to get bailed out. For one thing, they've been a great partner and an ally in our fights, and Boeing is standing up direct primary care. So they deserve it, but so do a lot of other Americans that are in the service industry that is a part of the economy that has just been eviscerated in the last couple of weeks. So I think something will be dealt with on that. So I would look to the next couple of weeks for another package to come together. We are aware that the House Ways and Means Committee and Speaker Pelosi on the House side are developing a second round of health reforms, policy issues that either didn't make it into these bills, fell between the cracks, or things that got pulled out. So we'll be seeing in the next few days what some of those things might be. But I feel quite certain there will be another round of stimulus and healthcare policy bills coming pretty shortly.
That's great to hear. Now's the time for it. Well, so I want to get on to some audience questions. So we've got Troy Seibert here. He says that over the last 3 months, he started a DPC practice, totally unrelated to COVID. He has plenty of capacity to help with telehealth. How can he plug in?
Yeah, that's a good question. One of the things that, and of course, we've been working with our friends at Hint on this, and some of the members of the DPC steering committee. We've actually been approached by dozens of telehealth companies saying, "Help! We need primary care doctors." So, in the very short run, there are companies out there like Amwell and Teladoc that are willing to pay 30, $35 a consult for you to take patients that aren't your patients, and have a conversation with them. We've also been talking with the Office of the Assistant Secretary for Preparedness and Response. That office is very interested in finding capacity for primary care docs. We've talked to them about the idea of setting up a website or a hotline somewhere where if you don't have a doctor, you can go to basically look up a DPC doc. That is under development. We're working really closely, obviously, with you guys on some of that, but working with some of the telemedicine providers, again, to make sure they understand that some of the regulatory barriers to doing telemedicine have been removed, and to understand questions around the opt-out, because a lot of these telemedicine companies will not send consults to physicians that have opted out of Medicare. Generally speaking, we think there's going to be a blanket waiver, but if that waiver, if that bar is in their contract and you won't be, picked as a doc if you say you've opted out, then that's a problem. We're trying to work through some of those with some of the companies that have approached us, and think we'll have some answers pretty shortly. The short answer is that, again, the emergency care and urgent care exception should get around that for any COVID related kind of things, and we should be able to rest on that authority. And we're seeking further clarity on whether or not we can have a broader overall waiver of the opt-out, which would allow DPC docs that have already opted out to treat Medicare patients and essentially bill back fee for service for telemedicine consults.
Great.
We know it's not DPC, so we're also trying to figure out how could there be a DPC solution? Is there a way in the short run where you could go and pick a DPC doc, go hire them? We want to be very careful about, the idea of looking like we're profiteering on something like this, going out and starting to charge individuals, for a telemedicine, arrangement in a time of need. I think it's a stretch to say that that's any kind of profiteering, but we want to make sure we understand the rules of the road about that. But I think very shortly we ought to be able to come up with something that will allow people that are medically homeless basically to come and join DPC, and this would be a great way to sort of expand the capacity that DPC has to take care of patients. I would also say be in touch with us. Leave us a message at info@dpcare.org, or be in touch with Hint. If you have capacity and you want to reach out, we'd like to know that. I mean, we've talked to members of our steering committee about people who do, some don't. Some do. Some have practices that are almost all Medicare, and they're super busy, and then some do not. And I presume that most DPC docs with their regular patient panel of 500 or 600 are probably already sort of triaged their patient populations and are doing what they need to do. So could have some time in the day to otherwise take some calls, and we'd like to facilitate that, knowing that it's not DPC, but it's what you can do to help your country right now.
Right. Yeah, Troy, it was a great question, and I know a lot of other people have that same question. And by the way, welcome to DPC, 3 months in. So Hint is working on this as well. You can go to hint.com/virtual care, and we're assembling a directory of DPC docs that are in the same position that you're in, who have some extra capacity, have the willingness and the ability to deliver virtual care. And we're going to be working with Jay and Jay's organization and others to publicize that list, going direct to consumer.
Yeah, and I want to say that we've been working really closely with Julie Gunther and the Alliance. the coalition, the alliance are stepping up to work together on this. Even though we're sort of the policy group and the alliance is the DPC membership advocacy group and mentoring group. There's no daylight here. I mean, this is all hands on deck, and we're all working together on this one.
That's right. Great question, Troy. All right, question from Ben Aiken. Hey, Ben.
Hey, Ben.
So Ben just has a follow-up question on the Primary Care Enhancement Act piece. So just to be clear, were no parts of the Primary Care Enhancement Act included in the CARES Act? It just made it through
No parts of the Primary Care Enhancement Act were included.
All right, but we've got another swing.
All parts were in the first version. No parts were in the last version. Sadly, on the cutting room floor.
So Jay, we've got a question here from a familiar face who you and I both know, from Kenneth Q. Hey, Kenneth. So is the opt-out provision specific to COVID? Will Kenneth be able to work at an urgent care in the future if he's opted out of Medicare for his own practice?
So right now, the opt-out provision that, as I understand it, for urgent care and emergency care. And by the way, this is a Phil Eskew question, or a Cat Nickel, or talk to your lawyer, because I am not a lawyer and I do not play one on TV. But our read of the opt-out provision is that for emergency care and urgent care, there's a general waiver on it. So you should be able to do that, and talk to Phil about his moonlighting experiences, and he can, I think, give you some insights there.
Phil Eskew, yeah. All right, we've got a question from a repeat visitor who was on last week, Maribel Avales. Is the DPC physician legally responsible? This is a great question. Is the DPC physician legally responsible to advise patients not to use their HSA card for their monthly membership payments? And if so, to what extent? And then is the DPC liable for any HSA misuse by the patients?
So Maribel, the first question I would have for you, and this is a very important question, is, are you a tax attorney?
I'm going to say probably not.
In addition to being a doctor? Well, be careful, because, we do have MD, JD, MBAs floating around out there at DO. Yeah. So if you're not a tax attorney, I believe, again, not being a lawyer, you should not be offering your patients tax advice. The fact of the matter is that the HSA statute, the way it is drafted, it is completely, the onus of enforcement is on the IRS, and they've taken one enforcement action that I know of years ago, but they're not widely enforcing it, and that's not something we want to tout. But there is no liability for the doctor here. It's all on the individual. So the rules say if you have an HSA, it has to be paired with a high deductible health plan. And if you have this other coverage that the IRS defines DPC as, it simply makes you ineligible to put money into your HSA. If you have an HSA and you don't have any money in your HSA, then there's no sort of restriction around it. The question around whether or not you can take money out of the HSA and pay the doctor, you don't know what credit card that is that he's paying you with, he or she is paying you with. I think I don't think there's a high risk here, and the sanction would be against your patient if the IRS were to ever levy any sanction, and that sanction would be that they'd probably have to pay tax on that HSA dollars and defund the HSA immediately. So those are sort of my understanding of the risks. The more important place the risk comes into place is that virtually no employer, knowing that these ineligibility questions are out there, is going to put together a DPC arrangement if they have a large portion of HSA high deductible health plans as a part of their payer mix. So it really is, these restrictions really apply more to employers being able to sort of supercharge DPC and go out there and wrap DPC in as a part of a self-insured or employer-sponsored health benefit. So that's where the real problem with this provision comes in my mind.
Thanks for the question, Maribel. Got a question here from Joe Fields Johnson. If I have my own clinic telehealth service for my own patients, can I start new patients who are enrolling in primary care through my DPC as telehealth until the crisis settles?
So that's the question for the hour in Section 3701 of the CARES Act, the new bill. By my read, there's nothing that says that you can't offer a telehealth benefit, through a company, through a high deductible health plan that would not make it ineligible. But you can't go out and offer it to an individual and have the individual pay and have the individual pay out of their HSA. It does not fix that part. All it simply says is that if a company pays a telehealth provider, which you would count as a PMPM fee, that company can pay that without making the individual ineligible, number one, and number two, without making that individual, without counting towards that individual's deductible. So it's a good benefit but it's strictly for a company that would offer that benefit and not for not for an individual DPC practice going out to individual members.
Great. We've got a question here from Natalia Sutherland. So Natalia asks, if you're opted out of Medicare for your practice and a Medicare patient needs telehealth for non-emergency conditions or for whatever reason, are you legally able to see them via telehealth without a membership in your practice?
I think that's unclear right now. And again, it would be another one of these things I think you should, we are seeking guidance from the administration that during the COVID crisis that really all opt-out restrictions be waived, because obviously if you're you want to be able to treat your patients for non-emergency and non-COVID related things. But if it isn't urgent care or emergency care, there isn't a blanket waiver in place already. And my understanding would be that no, it's probably it probably isn't covered. That being said, there is just, again, when it comes to telemedicine, there is this attitude that the administration has been taking, is that we're waiving any possible restriction that we can, and that's certainly a restriction, and we're waiting to get further clarification on how that works and how that would work, but we don't have it as of yet. But stay tuned. As soon as we hear, we'll let you know.
And Jay, they can updates. What's the best way for people to get updates from DPC Coalition?
Well, certainly we'll be posting updates on the website and sending things out through the mailing list. If you haven't already, we would encourage you, if you're not members, please join the coalition. Now more than ever, we need everybody to sort of gather around and help us push for these reforms, not just the HSA piece, but the state legislation we've been working on, all the things we work on with the administration, and the deep dive that we're taking with Medicare on direct contracting and other things. But certainly check the DPC website, DPC Coalition website. I'll be honest with you, in the last week or so, we have not been really good at putting updates on the website because it's really been a question of bandwidth. Sadly, working from home, working 24/7, we've had just enough time to fight the fights that we need before we've had an opportunity to put things up. But as things slow down after the bill passes, we'll have all of these resources up. There's a COVID resource section that's up there now. There's some information. It's probably about a week old, but in the next 24 to 48 hours, we'll have all this up on our website, dpcare.org, as well. And please join and be a part of this. I mean, I think it's critically important that we all rally together and do the things we need to do in DC to make sure the policy gets done right and it gets done permanently.
That's right. Have there been any hearings in Congress on the DPC high deductible health plan fix? That's a question that came through from an anonymous attendee.
Sure. We had a hearing in the Ways and Means Committee back in October and a markup. We had a full hearing on the HSA bill from last year as well. There's not been a Senate hearing, but there's been Ways and Means hearings and markups.
Gotcha. Question here from Nikki Parquette. So if they're Medicare opted in, can we see Medicare patients via telehealth?
Absolutely. You're if you're opted in, virtually every barrier you had, whether it's payment, parity, HIPAA, geographic waiver, requirement for first-time visit, all those things are temporarily waived for the duration of the public health emergency. And if you go to CMS website and just Google the term CMS telehealth, those guidances will come up, and we're going to post them on the site immediately after we're done with this as well. There's a whole set of FAQs for Medicare and telehealth and Medicaid as well. Very similar kinds of waivers in Medicaid. Those are subject to the 1135 waivers, and my understanding is there's only about 11 states that have taken them. But on the federal side, any federal restrictions around Medicaid and telehealth have been waived.
Gotcha. One more question. I'm going to do a lightning round here. We've got about 4 minutes left before we hit the 9 o'clock hour on the East Coast. So other than the note that the doctor creates, is there any kind of proof requirement related to telehealth or video-based patient encounters? Like, do they need to store a recording of the encounters in their EHR or timestamps or anything else for their reimbursement?
I think the assumption that it's going to be a fee-for-service transaction, so any kind of normal coding that you would do with Medicare or an insurer, you should be doing. But again, check with your.
If they're doing coding.
Say again.
And if they're not doing normal coding ever.
Right. You're going to have to code. I mean, again, this is where this helping out thing is it's not DBC. But so one of there is a resource, and let me see if I can share this. There are on this document. Is the document up?
Yes, sort of.
There are on this document a number of codes, and I can't scroll it now for some reason. Wait, here it is. Yeah, I'm back on the other one. There are a number of codes that are listed on this telehealth CMS telehealth website that are specific. The AMA also has a document that lists all the telehealth codes. They're just like right out there for you, and they just need to be documented for a Medicare transaction.
Great. And Kenneth mentioned in chat that that might be a good question for the AAFP. So maybe check out their site for resources.
Yeah, AAFP I'm sure has the same resources. Oh, I found it. Is this scrolling up now?
Yeah, you got it.
All right, it's just I got too many things open here. Yeah, and this isn't the darn document anyway. Yeah, that's the regular list, but we'll get the codes and put them up on the website. Make sure you have them.
Okay, so we have an enthusiastic question here from Cynthia Velasquez, who says, "Wait, so I can have Medicare patients join my practice right now if I am not opted out?"
That's not my read.
Okay, so not necessarily.
Talk to your friendly DPC attorney.
Gotcha. So it's a good question for Phil SQ or Kat Nickel.
Yeah.
Great. We have a question about the legislation about Primary Care Enhancement Act versus some other ideas that are out there. So can you talk about Primary Care Enhancement Act versus the Personalized Care Act?
Is that the Cruz bill?
I'm not sure. I think it might be.
So,
there's a question from
Care Enhancement Act is the only piece of legislation out there that only addresses the direct primary care issue. There are a number of other bills, and we are very supportive of all this legislation that essentially wind up being legislative vehicles to expand the use of HSAs. We don't really take a position on HSAs, but if HSAs are a tool that can be used with people that have high deductible health plans in conjunction with DPC, we think that the other gloves for the HSA stuff ought to come off. And we're 100% supportive I think the fact of the matter is, we've gotten a lot of traction, and even though we got this far, we had the ranking member of the finance committee pull us because he didn't really understand exactly what it is that we're offering as a service. The HSA, the larger HSA bills, number one, come with a huge price tag, upwards of $40 billion over 10 years, which is, maybe in today's light doesn't seem like such a big number. But they are also almost exclusively supported by Republicans and opposed by Democrats. So should the president win re-election and get a Senate with more than 60 votes, then, candidly, even then you've got the budget hawk issue with a lot of conservatives that might come into play. But then we can start talking about expanding some of the other things that are out there. And we realize there's some restrictions in this bill. And it's not perfect, but those restrictions are very light. And the restrictions are essentially that, $150 PMPM indexed for inflation. There's not that many practices that are charging that anyway. And we're not telling you how much you should be able to charge, but they are telling you how much triple tax preferred, federal, dollars are going to be able to go to support these kinds of things. So, let's get this passed and we'll keep working on it. We'd like to see those restrictions moved. We don't love them, but if it's the price of them getting done and it's a 99% solution for everybody, then they ought to get done in a meaningful fashion. This is a solid fix, a 100% fix for almost everybody. And there's a few people that we know we've lost a member or two because they charge more, and this they wouldn't be, and they have virtually all HSAs in their practice. So they just cede back to current law. So there really isn't a change from where you are today if this thing passes. It's a great solution, and it's the one that will fix us more permanently. But then, we're going to keep working to expand, more of these market-based ideas because we like them.
That's right. Chances you think we get something through this year, one way or the other?
I think they're very good.
Great.
I didn't say that in previous years, even last year, when we actually passed this provision out of the House Ways and Means Committee and then out of the full House. And of course, at the end of the year, we blew up the world and shut down the government and didn't have a pathway to pass this thing through the Senate. But we've gained a lot of momentum from that. I think the most important piece is that, right now, we do not need to go in and spend 20 minutes talking to people about what is DPC and how great it is. People get it. People understand it because this issue has been very well vetted. It's ripe. It's ready to go. We have liberal Democrats like Earl Blumenauer, who are some of our biggest supporters. And we have the President of the United States, Donald Trump, who wants to use DPC as a way to improve transparency as a part of his executive order. What other policy, well, until today, of course, what other policy is out there that's been that bipartisan? I think we still have that bipartisan support. We need to rally around this bill and get it passed. I know there are some people that have some differences with some of the things that are in it, but let's not be the children that are crying in the middle of the grocery store because we got the green lollipop instead of the orange lollipop. We got a really good lollipop.
That's right. Well, hopefully we can get Congressman Blumenauer to talk to his friend in the other paper.
Believe me, they've been talking. And I mean it when I say we need to act in good faith with Senator Wyden, who is the ranking member of the Finance Committee and will either be the ranking member or the chairman next year as well. So we're talking with the staff. We're trying to overcome them. You'll see a document on here that's a set of talking points called DPC is not concierge. I think it's really important if people want a message to Ron Wyden that they message that DPC is not concierge. And here's why it's relevant to COVID, because we want to move to virtual care, and this is the best virtual care model out there.
That's right. Great. Jay, thanks so much for your time late at night. And thanks to everybody who joined the call. We had a really good showing today. We had over 50 people on the call. And we will have more of these, so stay tuned. Again, you can go to hint.com/COVID-19 to sign up for, you can sign up for updates about COVID-19. You can get updates on the next time we're having one of these live streams. We'll probably have one next week. And we have some other resources there as well. And then there's hint.com/virtual care, where you can sign up to offer virtual visits. We also have VDPC-sign up here. It's on the screen.